not least, and I've been particularly looking forward to this last talk for what is a really difficult kind of subset of patient presentations that can be really tricky to manage, and that is the degenerative knee. To give us her insight and expertise in management of this particular case, we have Helen Vint, who's a consultant orthopedic surgeon at Northumbria Trust. She trained in the Northern Deanery, doing a fellowship at Bristol and Coventry. Her elective practice focuses on knee surgery, experiencing cartilage, meniscal ligament injury, repair and reconstruction, and also in terms of osteoarthritis, both compartmental and total knee replacement surgery. So without any further delay, I'd like to introduce Helen Vint to give us a lecture on the degenerative knee conundrum. So over to you, Helen.
Hi, good morning. Thanks very much for inviting me to come and talk. As you've described, my name is Helen. I'm currently away on fellowship in Bristol at the moment, and I have a particular interest in knee preservation surgery, and I'm down in Bristol to learn about some specific techniques, including patellofemoral surgery. But this morning I'm here to talk about the degenerative knee conundrum. I should add that I've got no relevant disclosures, and I'm delighted to be offered the opportunity to come and talk to you and start to build some relationships with the physiotherapy and primary care community in the Northeast. So the agenda for today is to talk through some early degenerative knee conditions, talk a little bit about the conservative treatment options available to us and what we as surgeons have on offer to you and the kind of outcomes that we can hope to get. This is more of a synthesis of how I think about things and my practice rather than an exhaustive trawl through the literature. And I'm much more used to presenting to orthopedic surgeons rather than physiotherapists, so I do apologise if I haven't pitched it right in terms of the level. So I want to get you guys involved, and to start off with, we have a patient for you, and it's a common patient that you'll be used to seeing in the Northeast. So this guy is 40, so pretty young, and he presents to you with a 12-month history of intrusive, persistent medial-sided right knee pain. So it's there all the time, it gets worse with activity, it wakes him from sleep, and it's starting to interfere with his work as a welder, so he's sort of struggling to get through his shifts now. He's previously had a medial meniscectomy as a much younger man, and as I said, he's now got persistent medial-sided pain. Normally he keeps quite fit, he likes long-distance cycling and going to the gym, but increasingly that's not possible for him anymore. And he's been having, he's had a targeted course of physiotherapy for a while now. And in fact, your colleague's been seeing him for a while and has referred him for some x-rays. Now, I know you guys don't always get the benefit of seeing the actual images if you work in peripheral clinics, but you have the benefits of the images today. And these show that he's got mild medial compartment arthritis. That's what the report says. And in fact, your colleague has actually gone on to get an MRI scan as well in the community. And the report from that shows that your patient here has got mild to moderate medial arthritis with a complex degenerative tear of the posterior horn of the medial meniscus. So right, we've got a chap who's 40, he's got good going symptoms that are persistent there all the time, interfering with work, and he's got medial compartment disease, so what we describe as a failing medial compartment, partly arthritis, partly meniscal tear. So I think historically these are the type of patients that we've struggled with as a musculoskeletal community, and we haven't always had brilliant treatment options for them. And I think historically, if these patients had been referred to secondary care, they'd have been given a pat on the head, they'd have been told to take painkillers, probably opiates, and told to suck it up and get on with it until they were 50 and could have a total knee replacement. So these are the kind of patients that we're going to focus on today. They're sort of mid-range age patients with degenerative knee conditions. And we're going to cover the sort of useful investigations to get in primary care, the role of bracing and injections, and what surgical options we can offer these patients. So I want you to think about how you would personally treat this patient if you were seeing them in your clinic. And so I've got some options for you, and it's going to bring up a poll here. So these are your options. You can opt to give this patient a knee brace, steroid injection, or some other kind of injection if you've got access to that. You can refer them for an arthroscopy, you can refer them for a high tibial osteotomy, or refer for a unicompartmental knee replacement. And I should point out that the patient has had physiotherapy and they've still got ongoing persistent symptoms. I'm not ignoring physiotherapy as an option. I'll give you a couple of minutes, well, not a couple of minutes, I'll give you a few seconds to vote on that. We'll see what you think. Okay, so loads of people opting for steroid injections. Okay, cool. And lots of people opting for a knee brace. Interesting. I wonder what kind of knee brace you're all opting for. So, moving on. So the first thing to talk about really is the type of x-rays that we get. So I know that not all of you will have the ability to request your own x-rays. But for those of you that do, it's important that that we discuss what are the best views for showing up the type of conditions that you want to see. So obviously x-rays are cheap, easily accessible, low morbidity investigation to get for any patient where you think that arthritis is likely to be the source of their problems. So probably any age from 35 above, or if you're suspecting that fracture might be a problem. So baseline x-rays are always, nearly always a good idea, and it would be unusual that I would jump straight to an MRI scan really. And so you can see we've got a weight-bearing AP and a weight-bearing lateral. It's important to get weight-bearing views if you're looking for arthritis, because what we're looking for to diagnose arthritis is joint space narrowing, and you're going to see that best if the patient's actually standing on their leg. Now, if you've requested the x-rays and you've put the reason for the x-rays is query arthritis, then the radiographers will always do them as weight bearing. But it's important to make that clear. And then the real game changer here is the Rosenberg view, which I don't see often requested in primary care, but it's the most sensitive x-ray to look for early tibiofemoral disease. So this is the same patient here, and you can see that on the AP it looks pretty normal, but on the Rosenberg view you can see that they've got quite significant lateral compartment arthritis there. So that's worth knowing about. And that Rosenberg view you take in sort of slight flexion there, and what it does is that the wear tends to be more severe on the femoral side in mid-flexion, so it just shows it up better when they start to weight bear on that part of the femur. So it's definitely worth trying to get a Rosenberg view. The last view to think about is the skyline view, which is useful to show up patellofemoral arthritis. As you can see, bone-on-bone arthritis in these views here. Overall, I would counsel you to, if you ask for the right views, you're much more likely to get a helpful answer that fits in and correlates with your clinical findings. And I guess I would caution you slightly to on how you interpret the x-ray report. And if you have access to the actual images yourself, I'd really encourage you to look at them personally and get better at interpreting x-rays yourself, because I do find that the reporting can be a bit variable. So I'll often see x-rays that have been reported as you know, moderate arthritis, and they'll have extremely severe arthritis, or x-rays that are reported as normal but have subtle changes of early arthritis, or the right views haven't particularly been taken to my mind. So I guess what I'm trying to say is I'd go with your clinical assessment and believe the patient about their symptoms, maybe a little bit more than you believe the X-ray reports. So we mentioned before that your colleague had actually already arranged an MRI scan for this patient. So clearly, you know, when would an MRI scan be helpful for you in the context of degenerative knee problems? So what we're really thinking about is, does the patient have arthritis? Because if they've got established arthritis, then you probably mainly got your answer there. So I think an MRI is not very useful if they've got established arthritis in most cases, but if they've got very little in the way of arthritis on their x-rays, then it might be a goer. And what you're looking for on a scan is a meniscal tear or ligament pathology. So if they had prominent mechanical symptoms, so a feeling of catching or intermittent pain or locking in the knee joint that was suggestive of a meniscal tear, then an MRI might be helpful. Or if they had instability symptoms suggestive of ACL injury, then again, it might be useful. Sometimes an MRI scan is helpful to diagnose arthritis if you really don't see anything on good quality X-ray views, but I would say that that's kind of more of a niche indication. So for me, for this patient, I think that it's probably more useful for me to get really good quality X-rays rather than an MRI scan in this scenario, particularly in light of the symptoms that I was trying to describe to you, and of chronic, persistent pain that's there all the time. So not exactly in keeping with meniscal type pathology. So now that I've given you this scenario so now that you have had an MRI scan, you know that the patient does have a meniscal tear, plus they've got some early arthritis. So do we need to do anything about this meniscal tear? Well, it sort of a bit depends really. As a general rule of thumb, I would say that if patients have repairable meniscal tears, particularly in younger patients, then we will try and repair them. So meniscal pathology is a whole different talk on its own, and there are lots of different types of tear as I've shown you here. But in the main, we try and repair menisci to preserve their load sharing function in the knee joint and to try and preserve the knee joint generally. However, sometimes if patients have got degenerative flap tears in the knee joint that aren't repairable, like the two that are shown in the bottom right of the screen there, then we will take them away with a partial meniscectomy, particularly for patients who've got prominent mechanical symptoms that are suggestive that the meniscus is the problem, i.e. catching, intermittent pain, but some days are all right. However, if you've got a patient who's got a generally failing compartment, so they've not only trashed their meniscus, but they've also trashed their articular cartilage and they're starting to get arthritis, it's much less likely that I'd offer them an arthroscopy and meniscectomy alone, because it's not really addressing the main pain driver and cause of their symptoms. So I'd be thinking more about trying to do something to help with their arthritic pain rather than just addressing their meniscus. That said, there are some caveats to that, and occasionally you'll see patients that got early arthritis, but they've got a stonking great big meniscal tear that's flipped into the wrong position, and they've got really prominent mechanical symptoms, and those are patients where it's probably worth giving it a go at meniscectomy. But definitely it's a key take-home message for me is that meniscectomy alone is not the answer if they've got symptomatic OA as well. So lots of you said that you wanted to inject this knee with steroid or other injection. So there's been some interesting literature that's come out in the last few years about steroid injections. And I guess I guess I've moved away from injecting as many knees as I used to. There's one particular paper that was published in a radiology journal. It's by no means a perfect study, but basically they looked at in a large number of routine hip and knee steroid injections, and they found quite a stonking 8% complication rate when they followed these patients up, both. And the kind of complications that they were seeing were they're not insignificant complications either. So they were seeing things like rapid progression of arthritis, subchondral fractures, so that's fracture just underneath the joint surface, or actual death of the bone. And so the rapid OA progressions were at a higher rate than those that they would expect in a non-control group. And I think, I guess my practice more now is a sort of more sparing use for acute exacerbations of people's pain. So I'd be looking at using steroid injections when patients have had, they've been bumbling along with their arthritic pain, but it's got much worse in recent weeks, and they're having a bad episode, or if they've got a particular event that they need to go to, and they need to try and get through that. But I'm not using it nearly so much as I used to. And then I know somebody's going to ask me about the use of PRP or hyaluronic acid or lipogems, and we're starting to see this more and more in private practice. People are starting to use these kind of injections. Now, this is something that I don't really have access to in the NHS at the moment, and it isn't part of my practice. And it's certainly an exciting area of orthopaedics, and I'm sure we're going to see a lot of emerging evidence about this subject in the next 10 years. But currently, for me, the evidence just isn't quite robust enough yet to be using these type of injections and spending NHS money on them. So is there anything else that we can do in the community? We mentioned bracing as an option that a lot of you were pretty keen on. So lots of patients will turn up with the kind of simple knee braces that you see on the left-hand side of the screen. And I think they work to an extent in a sort of non-scientific way. I think they work with a feeling of support and warmth and comfort for the knee, and a sort of reminder that they've got a bad knee. But what's actually a really much more powerful tool for patients who are appropriate for this type of brace is what's called a medial offloader brace. And we use this for medial compartment arthritis. And so how this brace works is it's basically a 3-point leverage system to crank open the damaged side of the knee joint and offload the damaged side and take more pressure on the good, healthy side of the knee joint. So if we look at a similar patient now, who you can see in picture A has got early medial compartment osteoarthritis with a smidgy bit of joint space narrowing. And then on the right-hand side, you can see long leg alignment views. So these are views that you can only really get in secondary care, I'd say, because you need to have specialist X-ray equipment to take these pictures. But what the alignment views does is it allows us to draw a weight-bearing axis on each leg. So that's drawn from the center of the femoral head to the center of the ankle joint. And you can see that on the normal left knee, the weight-bearing axis passes through the middle of the knee joint, whereas on the right knee, as they've started to wear out their medial compartment, the joint is gradually tipping over into varus, such that the weight-bearing axis of the joint passes well into the medial compartment. And this sort of adds insult to injury, because as well as having a damaged, unhappy knee joint on the medial side, they're now loading it even more because the weight-bearing axis has tipped over, and that gives them even more propensity to start to wear out that side of the joint even more quickly. So how the brace works is, so you can see on the left-hand photo, you've got the knee joint with medial compartment arthritis with no brace on. And then on the right-hand side, you can see that with the brace on, to an extent, it cranks open the medial side of the joint, and it gives the patient a more neutral alignment on their long leg films to take more of their weight through the undamaged lateral compartment. I think it's important to be aware that this is quite a powerful brace, and you want to make sure that you're prescribing the right brace for the right patient. So you use a medial offloader for medial compartment arthritis. You use a lateral compartment offloader for lateral arthritis. And if they've got arthritis in both compartments, then you cannot use this type of brace. They don't work for all patients, but it's worth giving it a whirl. In my experience, I use a lot of them in secondary care. Some patients really get on with them, and they find that they basically can't walk really without them. And some people, they find the pain worse, so they're patients that you should just tell them to get rid. It's important to tell the patients to take the brace off when they're not walking around, because otherwise they rub. There's no benefit in wearing these type of braces when patients are sleeping, basically. So I do use these braces a lot. I have that's partly because our waiting lists are very long in Bristol, and they're a good sort of stopgap treatment for patients whilst they wait for surgery for us. I don't know what access you have to these kind of braces in the Northeast, but I can tell you that you should have access to them via your orthotist, or even better, you will have access to them on prescription. So GPs in primary care can prescribe medial offloaders braces, and the only one that's available is this 2-AIN medial offloader brace that's shown on the left-hand side. There are loads of different medial offloaders on the market, but it just so happens that this is the one that's approved for NHS primary care prescription. I should point out that I have absolutely no financial interest in this company. Okay, so now we've got a chap who has been braced, and he's getting on well with his brace, but he's asking you if there's any more permanent solution to the symptoms that he's having. So next, I want to introduce the construct of the reconstructive ladder. I think this is a really beautiful description of the ladder of surgery in the knee joint. And this is something that Romain Sale, who's a knee surgeon from Luxembourg, published about. And I just think it's a beautiful description of the concept that we're trying to describe. So on the x-axis at the bottom, we have time, and on the y-axis we have disease progression and treatment invasiveness. So low down in the green box, we have, perhaps the patient initially presents with some kind of injury. Perhaps they have an ACL rupture with an associated meniscal tear. And these are patients where we would try to, as best as we can, return their knee joint to its original state. So we would try to repair the meniscus, reconstruct the ACL ligament, repair any osteochondral defects. Bracing is also included in this area, in this box, and also osteotomies. So an osteotomy is a surgery that's sort of similar to a brace, really, in that it's designed to offload the damaged compartment of a knee joint and start to put more of the body's load through the undamaged side of the knee. And so, as I said, as best we can, we try to keep patients in the green box for absolutely as long as possible, so that we stave off when they're going to need joint replacement surgery. So into the orange box of reconstruction, so partial knee replacement or total knee replacement. So these are great options. I'm not knocking knee replacement as an option. They're brilliant options for patients that need them, but they're not good options for younger patients. And if you're a patient who ends up needing a total knee replacement in your 40s, then that's a real worry, and we'd be much more worried that you're going to skip ahead and be in a situation where you're in the red zone of needing revision knee replacement, or ending up with an infected revision knee replacement, a fusion or arthrodesis of the knee joint, or even amputation within your lifetime. And clearly those are all operations with poor, well, potentially poor patient satisfaction. So for us, increasingly, I'd say we're trying to focus on knee preservation surgery and opting to give people joint replacements as and when we need to, but trying to stave off doing that until later in life, so that we don't end up in the red zone. And with that in mind, I hope to talk a little bit about osteotomy. So back to that picture that I showed you before. So if you remember, on the right hand side, we've got a knee that's starting to tip into varus, so i.e. being bandy-legged. And what an osteotomy does is it aims to change the shape of the bone to realign the leg to give you a more neutral axis. Okay, so what is it exactly? Well, thanks very much to Dave Elson, my esteemed osteotomy surgery colleague in Gateshead, for this image. So this shows a high tibial osteotomy. And here you can see that we make a controlled cut with a saw blade across the proximal tibia here. And that's done through a sort of 2-inch vertical incision on the proximal tibia. And then we very gently open up a space in the bony cut there, and tap in a carefully calibrated metal wedge to hold the bone open, whilst we pop a plate and screws on the side to hold the bone open in that new shape. So that's a high tibial osteotomy. And what that does is it gives you a more neutral alignment, as I said. It doesn't magically restore the damaged cartilage that's already been trashed, but it helps to relieve their pain. And then over time, that bony space that you can see there will fill in with bone, and depending on the patient, that can take anywhere between 3 and 12 months. This can be done as a day case procedure, and sometimes patients will stay in for a night. I should be completely honest here and tell you that it can be a painful procedure. It's on a par with a unicompartmental knee replacement, I would say. And certainly for the first few weeks, patients are not always happy with you. Usually by the time patients come back to see you at about 6 to 8 week mark, they're normally off crutches or using one crutch, but it can take longer than that to see the real benefits of the procedure in terms of significant improvement in their medial sided pain. It just depends. Essentially, in the long term, there are no restrictions in what a patient's allowed to do after they've had an arthritis. So if you've got a patient who really enjoys a lot of load-bearing exercise, like running, then there's no restriction on what they're allowed to get back to. So who are the sort of ideal patients that I'd be looking for, who I'd want to give an osteotomy to? Well, they're kind of a bit like this guy. So they're people who are, you know, they're not massively old. So they're maybe in an age range of sort of 30 to 55, but they're active. And the age range thing is controversial, and orthopedic surgeons will like to argue about that. But that's the sort of ballpark of ages that I'd be looking for. They've got to have unicompartmental disease. So for medial opening wedge high tibial osteotomy, we'd be looking at patients who've got medial compartment disease. There is another option for patients who've got isolated lateral compartment disease. It's a surgical option that's particularly useful in knee preservation surgery or for those with early arthritis, but you can use it in established arthritis as well. I think it's a good option for patients who are active, who can tolerate a bit of pain and get them through this operation, and who are more on the slim side. So this isn't a great option for patients who are morbidly obese, because realistically they're going to have to be on crutches for a wee while. It's not a good option for patients with rheumatoid arthritis, because that's a systemic condition that will potentially affect the whole of the knee joint. So you can't trust that the lateral compartment is going to be in good condition. And for me, I personally don't offer this operation to heavy smokers because of the risk of non-union of the bone. In terms of the outcomes that you can expect, so the published data from the 3 largest osteotomy units in the UK shows that about 5% complication rate from this type of procedure, and the commonest complications that people see are things like wound infection, wound hematomas, and delayed bone healing. It's extremely rare to get the dreaded complication of an injury to the main nerve or blood vessel at the back of the knee, although that's clearly a worry for us as we pass a saw blade across the knee. Those same units have reported an 87% good or excellent results in the medium term. There are issues with outcome data in osteotomy surgery, partly because they're quite a heterogeneous group of patients, and our techniques have improved in recent years. But what I really want to hammer home is that we do have surgical options for early arthritis now. I guess not all surgeons offer them, but I'd encourage you to think about referring patients who are significantly symptomatic, even if they only have early arthritis. One thing we haven't talked about so far is partial knee replacement, but it is a fantastic option for older patients. So this is a patient who's got more severe arthritis, and on the left you can see an AP, and on the right they've done an attempt at a Rosenberg view, and this nicely illustrates the power of a Rosenberg view in demonstrating more severe arthritis. So who's the ideal patient for a unicompartmental knee replacement compared to an osteotomy? Well, I'd say that they are probably a bit older, so ideally these patients are over 50 in my practice, and you want them to have bone-on-bone arthritic change, because we know that patients do much better if they have severe arthritis, so it's not something that I would offer in early arthritis. Perhaps they've got a slightly less heavy manual labour job, because if they do something very, very heavy, then they're more likely to rapidly wear out their joint replacement. Partial knee replacements it's an okay option in patients who are heavy, and it's okay for smokers as well. Still, it's not okay in systemic inflammatory arthritis like psoriatic or rheumatoid, because again, you need to be sure that their lateral compartment's going to stay in good condition. And there are other technical features, like you need to have a stable knee to do this operation. So one of the other things that I think is worth thinking about in terms of how I think about things, so if I've got a patient that's sort of that I'm in two minds about whether to sort of try and herd them more towards a partial knee replacement or an osteotomy, is their ability to take sick leave. So I find that the recovery after an osteotomy can be much more variable. Yeah, so if they did a manual job, normally I'd expect patients to get back after 3 months maybe, but it can be variable. And if a patient tells me that they can only take a maximum of 6 weeks of sick leave before they lose their job or whatever, then I would be more inclined to offer them a uni, because for me it has a more predictable recovery time. So what are the outcomes following partial knee replacement? Well, so registry survivorship data, the Swedish registry shows more than a 90% survivorship after 20 years. And we are getting better results now with some of the newer cementless implants. And I guess you might say, well, why would you bother doing a partial knee replacement when you could just chop out the whole joint and do a total knee replacement? And the answer to that is, well, for one, the risks are in general lower, so there's a lower risk of death, and there's a lower risk of other medical complications, and also a lower risk of the dreaded complication of infection, partly because the wound is much smaller. The caveat to that is that partial knee replacements do have a 2 to 3 times higher revision rate than total knee replacement on registry data. And the reasons for revision are either from progression of the lateral compartment arthritis, or from occasionally from bearing dislocation or due to concerns from loosening. I think often historically partial knee replacements have been revised because of concerns about loosening, and these issues are hopefully going to be less with the newer uncemented implants. And also, having a partial knee replacement does feel different to having a knee replacement. It feels much more like a normal knee compared to a knee replacement. Patients are happier with them. There's a much greater proportion of patients reporting excellent results with partial knee replacement. So I think if patients are suitable for a uni, it's worth considering it. So going back to our patient from before, would we offer this gentleman a uni? And I think for me personally, there's two things that would put me off offering him a uni. Number one, he's very young, he's only 40. And number two, that he's got quite mild arthritis. So I'd not be that inclined to offer him a uni. So moving back to our original poll, I'm hoping to see what you think you do now, whether this has changed your practice in any way, or what do you think? And I'll give you a couple of seconds to vote. Cool. Okay. Great. So more of you are keen to give it a whirl with a knee brace. That's great stuff. So I guess I'm in agreement that I would probably opt for. I'm cheating because I gave myself two options. So a knee brace and think about high tibial osteotomy for this chap. I think it's a great option to get him out of jail to try and buy him some time before he embarks on his knee replacement career. As somebody who's 40, who's already got some arthritis, I think there's a good chance that he is going to need a knee replacement within his lifetime. But hopefully by doing an osteotomy, we can buy him some time such that the time point when he needs a unicompartmental knee replacement is maybe 50 or 55, rather than being in just a few years' time. So I guess the take-home messages here, just to recap, are that medial offloader braces are useful for medial compartment arthritis. Rosenberg views a really powerful way of demonstrating early tibiofemoral arthritis. Rely on your clinical judgment and the symptoms that the patient describes more than the X-ray reports. Put them together in context. Steroids, perhaps not as benign as we thought they were originally. Use them with care, and perhaps consider referral even if only early arthritis if the patients are significantly symptomatic. And we do have surgical options for early degenerative disease, so it's not all about total knee replacement. Thanks ever so much for your time.
Great, thank you, Helen. Some real kind of key take-home messages there that looking at the evidence on the poll have clearly landed. So that was great. We've got a few questions. That's it, yeah. We've got first question from Clem, which regards to post-operative rehab for your high tibial osteotomy patients. What are your typical timelines you'd advise for maybe weight-bearing status and progression for those?
Yeah, so I mean, different surgeons will do different things. Essentially, most people will allow them to weight bear straight away, but practically speaking, patients don't weight bear straight away because it just hurts. It hurts to weight bear. So regardless of what you say to them, they'll probably partially weight bear for at least for the first 3 weeks, just because it's too sore. And occasionally, if there's it's not uncommon to have what's called a hinge fracture during an osteotomy, and those are patients where we would deliberately say don't weight bear for the first 6 weeks, just to try and avoid having problems with losing the accuracy of correction. But that's a sort of specific scenario, and normally we'd let patients weight bear as pain allows, essentially.
Great, thank you. We've got a question from Lorna regarding if there is a BMI cutoff for consideration for high tibial osteotomy, but equally, is there a cutoff that might apply for unicompartmental or total knee replacement? I know it's a controversial subject area, but I appreciate your thoughts on that.
Yeah, I was sort of dreading the question about BMI because it's a bit embarrassing, really, that as a community of orthopedic surgeons, none of us agree. That there's absolutely no agreement whatsoever. And as far as I can work out, from my experience of working with lots of different surgeons in the Northeast for total knee replacement or unis, is that all surgeons have different cutoffs, and indeed all units have different cutoffs. So I think what we can tell our patients that is, if your BMI is over 40, then your risks do go up very significantly. So a lot of surgeons will try to get patients to lose weight if their BMI is over 40. But that said, some surgeons would take the approach that if you have a fully informed discussion with patients and they understand that they've got a modifiable risk factor, but they've been away and they've tried to lose weight and they're not able to do that, and they still want to proceed with joint replacement surgery cognizant of those risks, then some surgeons are happy to proceed. With regard to unicompartmental knee replacement, I would use the same cut-offs as for total knee replacement. For osteotomy, I don't have a hard and fast number in my mind, but bearing in mind that they're probably going to have to use crutches for 6 weeks and really rely upon them in a way that you don't so much for a partial knee replacement, it's a much bigger ask of patients. And also, it's an operation that's just better suited to patients who are a bit more active and really want to get back to a bit more activity and stuff. So people who have a very sedentary lifestyle, perhaps it pushes me away from choosing that as an option for them. But I think to sort of sum up the answer to the BMI question is, I'd definitely try and get them below 40 and even better under 35 if at all possible.
Great, thank you. I've got a question from Rob Tyre, which relates to consideration of factors other than the biomedical factors presenting that might predict success. So that might be presence of anxiety, depression, multi-site pain presentations, and how does those kind of presentations affect your decision making? And would you discuss that with your patient?
Yeah, absolutely, and it's a really hard conversation to have, isn't it? So it's something that we can definitely, as surgeons, be accused of not being very good at, in terms of recognising patients who've got fairly significant life problems, so depression and anxiety, major social problems, chronic pain problems, heavier opiate dependency. So these are patients that, I guess we're more reluctant to operate on full stop because the chances of obtaining significant symptomatic relief for them are less. And at the end of the day, they still carry the same risk of complications as anyone else, and I would say there's an even bigger chance of making them worse with sort of chronic regional pain syndrome and things. It is a difficult conversation to have with patients, so to say to them that your depression puts you at higher risk of a negative outcome, therefore I'm not keen on offering you an operation. It is a really, really hard conversation to have with patients. But I think that we're doing them a disservice if we don't tell them honestly that is the evidence.
Great, yeah. Thank you, Helen. That was great, and some real take-home messages for the audience there. That was brilliant. Thank you.